Welcome to the New England Institute of Technology Health Policy class for the Masters of Public Health for this quarter. Part of the class, as you know, is going to be a series of video interviews that I've had the opportunity to do with a number of the people who are involved in the creation of and the implementation of the Office of the Health Insurance Commissioner. We're hoping through these videos to tell the story of what the crisis was that led to the creation of OHIC, how that happened, and to give you insights from the people who were there. I think there's nothing better than really hearing from the folks who were on the ground at the moment to try and tell this story. So our first interviewee is an old friend of mine, somebody who worked with me in the whole creation of OHIC, and his name is Rick Brooks. Rick, you are right now you're the head of health system workforce transformation for the Executive Office of Health and Human Services, and we get to work together in that realm as well. At the time, though, you were the executive director of the United Nurses and Allied Professionals.
Right.
So tell us about UNAP, as we call it. What is UNAP? What did it do, and what did you do in that role?
So UNAP is the state's largest healthcare workers union. It has now, I believe, close to 7,000 members. It's continued to grow. Most of its members are registered nurses, but they also represent all sorts of healthcare occupations. Most of the members work in hospitals, although, again, they have members across the healthcare and, in some cases, social services sectors.
Mm-hmm. Why is it important for healthcare workers to have a union?
So many reasons. I believe that the most important reason is so that workers who provide services can advocate for themselves and for their clients and patients. When healthcare workers are organized and have a voice, they can effectively advocate for things like staffing levels, for safety, for adequate resources, as well as having adequate compensation, reasonable work hours, etc., so that people are drawn to the job, stay in the job, and are able to do the job well to the benefit of their patients and clients.
And let's just go there for a second. You and I were also involved in a fight that came out of a crisis, and the crisis was that there weren't enough nurses.
Right.
And the hospitals were reacting to that situation by making people work double shifts. It was mandated overtime, and we helped lead a campaign over a couple of years to fight that. Why was that so important?
Yeah, so mandatory overtime was a really terrible thing that nurses and some other healthcare workers had to endure for several years when there was a significant nursing shortage. That nursing shortage didn't just happen by magic. It happened in part because healthcare employers were looking to reduce their labor costs and were looking for ways to reduce the number of nurses. And they did, and in some cases that involved using non-nurses or just other technology or ways to try to trim a little bit of the labor costs. And at the same time, what was happening was that because of health insurance and other reasons, only the sickest of the sick were even being admitted into hospitals, and they were being discharged sooner. So you had people, the sickest patients, and at the most acute point in their illnesses, that's when they were in the hospitals. So at the same time that nurse staffing levels were being trimmed, patient needs were more acute, and that created an enormous amount of pressure on those nurses who were working. We saw a lot of turnover, people looking to reduce their hours or leave entirely, go into other settings that were a little bit more, a little less stressful, especially aging nurses. And all of this resulted in a shortage of nurses. And one of the ways that the hospitals in particular responded to that shortage was that they would require nurses to stay overtime, whether or not they had other obligations or whether or not they had the energy and stamina to do so.
Or the ability to mentally
continue to think and provide the skilled level of care that they were expected to do. The other thing that was the other reason for the mandatory overtime was that the staffing was so lean that there was no ability to flex. So if somebody called out or if a couple of additional patients were admitted, it was like, uh-oh, we have nobody, you have to stay.
Right.
And this was just an unsafe practice and one that was very demoralizing and actually accelerated the downward spiral of people leaving those jobs and exacerbating the shortages, and it just got worse. So our union wound up leading a campaign both in the workplace as well as ultimately at the State House to put an end to mandatory overtime. First, we sought to limit it contractually and at the same time to limit it legally.
Right.
And ultimately, we made progress on both fronts.
We were successful. I raise that because, especially this is the beginning of the quarter, I want folks to understand that there are a lot of policy levers within healthcare, levers that community members have, levers that a labor union would have, and there are so many policy issues within healthcare also. For folks getting their Masters of Public Health, there are going to be a number of different ways that you can engage in the healthcare world. But I think it's so important to see how policy plays such an important, how I think it's really important to see how policy has an important impact in people's daily lives as practitioners and as the way to look at patient safety. I was involved in this campaign not because I was a healthcare provider, but because I was an advocate on the behalf of consumers worried about that patient who was being taken care of, that nurse, at the 15th hour of their shift. Right. And were they going to get the right kind of medicine? I know that after 15 hours on a very stressful job, I'm not thinking clearly. So that is to say, here's another place that policy is important. And UNAP was involved in a lot of different policy arenas. So talk about that. You lobbied.
Yeah. You
probably, I don't know if you helped write legislation or analyze it. Talk about the work that you did as an outside person on a lobbying campaign.
Sure. So I wore numerous hats at the union. I was the director of the union. I did all the labor relations at Rhode Island Hospital, which of course is the state's largest hospital. In addition, I did the work around community relations and coalition building, and that largely took the form of political action. Political action both in terms of electoral work and legislative work. I did represent the union for a number of years at the State House. Previously, we had somebody else that was doing that. And some of that was about raising awareness. A lot of it was about raising awareness, messaging, communicating with elected officials and staff so that they understood issues like mandatory overtime. Well, what exactly is that? Why is it a public health and public policy issue? Why can't it just be dealt with in the collective bargaining arena, for example? It's a common question that we would encounter. And we would engage our members in our political action. So that was one of the things that was really a pleasure and very different about being a lobbyist for a membership organization, because I wasn't there just speaking for myself, or I wasn't there just speaking for some high-paid individuals or businesses, but rather I represented thousands of nurses and other healthcare workers who first of all, elected our leadership, participated in the election of state representatives, state senators, and statewide officers, and who understood the value of political action. And we would bring to the State House the issues of our members. We would also bring back to our members the responses of elected officials.
Right.
Of course, as part of the legislative process, there would be hearings on legislation. We would encourage our members to participate actively, to come to the State House for hearings. We had demonstrations at times where needed to demonstrate the support of more than just those who could participate at a hearing. We also had all sorts of letter writing campaigns, postcards, phone calls. As we became more electronic, email campaigns, social media, that kind of thing. So, it was lobbying was ultimately a membership activity.
What you're describing, and some of the students will have read about this, is building power.
Right.
What you're describing is the quintessential way that groups of people can have power at the State House, power to make change, because they do all of those things. If they had stayed home, you still would have, been able to say that you represent them. Mm-hmm. But when they come with you, and you are never doing anything for them, for yourself, without involving the people with you, it's much more powerful.
And we were very fortunate that we represented nurses and others who are generally well regarded, yes, by the public. But we didn't take that for granted. I always felt that nurses, too, could be potentially demonized, just as any other union membership might be, mm-hmm, as being self-interested and so forth. And so we were very aware of the importance of being patient advocates. Mm-hmm. And as nurses really inherently are, they're right, trained to be patient advocates. But that's not something that necessarily is viewed by the general public. Certainly those who are in our patients or family members experience that. But we made an effort to be outspoken as patient advocates and as advocates for a quality, affordable, accessible healthcare system.
We're going to be talking later in the course about messengers and who are the best messengers. Mm-hmm. The data does show that nurses in the healthcare field, in healthcare policy, nurses are the best messengers. They are routinely rated as people that that are trustworthy, and we will take policy information from nurses. So let's go back to the late 1990s and early 2000s. There was a lot of mess going on. I mean, in some ways it feels like some of the problems were simpler then. In other ways, it feels like all of the problems that we have now started then, and we were grappling with it. So mm-hmm, let's just talk about what that was like. The crises that happened with Harvard Pilgrim leaving. Then the Right Care program started to be bigger and bigger, and everybody said, oh, it's costing too much, and maybe we have to cut it back. And then the Blue Cross crises. So how did it feel to be at the State House trying to do what we wanted to do in and among all of those crises?
Yeah, it was a turbulent time for sure, and there was a great deal of unrest in all quarters. So healthcare providers, those that bill directly, like doctors, were absolutely mobilized and impassioned and angry, primarily at Blue Cross.
And I want to say, this was the Blue Cross of the 1990s and the 2000s,
absolutely,
not the Blue Cross of today.
Right. So just maybe so let me digress and just talk a little bit about my understanding of what was happening at that time. There had been a bit of a competition for a while in Rhode Island amongst insurers. Harvard Pilgrim had, or was it Harvard Pilgrim, mm-hmm, had come into Rhode Island. They priced themselves very aggressively. They priced their insurance products very aggressively. There was a little bit of a pricing war. All the insurers wound up losing money for a while, and Harvard Pilgrim ultimately folded. Blue Cross was hurting, even though it had the largest market share in the state, 70%, but market share that was not priced in a way that was going to be sustainable. They hired a new CEO or promoted somebody who had been with them for years, Ron Batista, who in some ways turned things around for them, but in a way that antagonized many of their partners. So their rates that they paid to providers were constrained, and providers began to feel the pinch of lower rates, or rates that were not keeping up with their costs. On the other side of the ledger, the rates that they were charging, their premiums that they were charging for their insurance products, were going up by double digits, and that was putting significant pressure on anybody who paid the bill, whether that was, in most cases, businesses, or increasingly that was being passed along to workers, as well as on the individual market.
Yeah.
Everybody who paid bills, premiums, was feeling the crunch of double-digit increases. And then on top of that, Blue Cross was growing their reserves very dramatically. Insurance companies certainly need to have reserves in order to bear risk if there's a particularly bad year or an epidemic or something. And that's well understood and accepted. But in the face of the cuts to providers, the increases to businesses, and a third thing, which were some very scandalous corporate practices that just sort of flew in the face of the cuts and the cuts to providers and increases in premiums. They were at the same time enriching particularly their CEO, who, while as I said, had perhaps turned things around, was being very lavishly compensated for that, not just in terms of salary, which you could still debate the appropriateness of a salary, but in addition, things that were sort of beyond the pale, where the company, it was eventually learned, had paid for the costs associated with the CEO's divorce, and I believe purchased him a car, a Mercedes, had paid for at least one house or maybe another house for his ex-wife.
You and I were not getting those kinds of perks when we were doing our work.
No, we weren't. Still aren't. And so it was raising a lot of eyebrows. And what's more, there were a number of political scandals at the time in which several elected legislators were discovered to have been on the payroll, essentially, of Blue Cross and a couple of other healthcare-related entities, in a way that was really, again, over the top. Some of them went to jail for it ultimately. And that was, also Blue Cross's doing in part. So Blue Cross was not, had really fallen out of favor. And there was a cry, understandably, to rein it in. And how do we control and regulate and protect ourselves from this sort of unbridled corporation, which was a not-for-profit corporation. It was created by state statute. It had a board of directors. I was going to say volunteer board, but actually,
not so much.
Yet another thing that was controversial at the time was it was discovered that their board members were quite well compensated for their time, which was very unusual in the nonprofit world. Not so unusual in the for-profit world, but in the nonprofit world, volunteer board members are actually volunteers.
Exactly.
So that too raised eyebrows, and all of this led to, it culminated with a cry for oversight.
Right.
And that led to ultimately the formation of the Office of the Health Insurance Commissioner. We can talk more about that.
The legislature could have done sort of a range of things, and we're going to explore that over the quarter. They could have done nothing. I mean, there are a lot of other cries for oversight and cries for help, and nothing happens. They could have simply looked at Blue Cross. And there was, in fact, a piece of legislation that we'll talk about that looked at Blue Cross and said, you can't do this with your board, and you have to have this kind of oversight. But they had the opportunity, because we gave it to them, in great part, to do something big and broad and unique, and they took it. Why do you think they took it?
Well, I would say in some ways it comes down to organizing, but there was a lot of combustible material there for the organizing. You can't, not all organizing is successful organizing.
Exactly.
This was very broad-based organizing. There were some unlikely bedfellows pulling in the same direction on this issue. So you had the business community and the labor community and healthcare providers all unhappy with what was going on at Blue Cross and in the health insurance world in general. It was affecting consumers because one of the consequences of the low payments to providers was that providers were bailing out.
Right.
They were leaving Rhode Island, or they were not accepting insurance. And so that was a consumer issue. And we've talked about the impact on businesses. It was also a worker issue, whether they were healthcare workers or not, because increasingly we saw a lot of labor strife at that time over who had to pay what share of health insurance. So once upon a time, ancient history, employers paid the full cost of health insurance. It was just kind of a given. Yeah. And as health insurance costs rose much faster than the cost of inflation or anything else, employers started to look for ways to manage their costs, and they did so either by passing along the cost to their employees, either in the form of just you have to pay 25% of the cost of the premiums, or passing it along by increasing deductibles and co-pays at the point of service, or reducing the
value,
the nature of the benefit package, so it's less generous benefit package. So that was a huge tension in the collective bargaining unionized world, and for non-union workers it was just the job doesn't have the greatest benefits in the world. So that was an issue for business. It was an issue for labor. For unionized healthcare workers, it was a little bit more nuanced in that it was because unionized workers are still workers, and unionized healthcare workers are still workers, and healthcare employers are still employers. So on the benefit side, they fight over the benefit. As a business, the workers and employers in some ways are in the same boat in that they want their services to be adequately paid for.
Right.
So while their premiums were going up as workers or employers, their resources were being shrunk by the insurers as healthcare providers.
Right. It is a really interesting kind of dichotomy that somebody who makes their money from the healthcare system yet has to buy insurance is tugged on both sides.
Right.
If you ever need to write a really interesting sort of deep policy paper, you can write on that subject.
Here's a little interesting aside on this. I remember during that time there was for some reason legislation was required to allow high deductible health plans, which are these $5,000 or more, $10,000 out of pocket before your insurance even kicks in. And I remember talking to the representative of the Hospital Association at the time, who was not opposed, in fact may have even supported the legislation, because he was wearing the employer hat at the time, thinking, well, our hospitals are employers and they need to be able to manage their health insurance costs.
Not thinking
that when you have a $5,000 or $10,000 deductible, all those patients who show up at your ER have no long-term relationship with your facility. When they get their bill and they have to pay it 100% out of pocket,
they're not. Good luck.
Your bad debt is going to increase.
It's going to go up. All right, so let's set the stage. we were organizing in the labor and community organization community, and employers were doing some organizing, and providers were doing some organizing, and we'll read about and we'll talk about with some other interviewees the rally that doctors did, which was unique. You know, we were at the State House a lot, but you didn't see 1,000 doctors or 500 doctors, however many it was, go up to the State House a lot. So all of a sudden it's down to, well, what's our bill going to be? How are we going to do this? And I remember that there was a push, and it looked like we were going to get something, and then it got stuck, and nothing happened. And you and I ran with some other folks an action where we brought a clock to the State House. Somebody made a giant clock, and I don't remember what was on the clock, but talk about the fact that, you know, let's talk about how creativity and just trying to get attention. Sometimes, you know, you want to just be creative. It's not always dry kind of testimony. Dramatizations,
humor, visual things that are good visuals are hugely important. They engage people. They are more likely to get picked up by the media. They just attract notice, and they reach people often in a non-cerebral, intellectual way, just at the gut, at the heart of it, and that includes decision makers. They're affected by that. It resonates. Or they know that their constituents are affected, and it's resonating with their constituents. So it's like a cartoon or something. It's worth 1,000 words. You know, picture. Yeah.
So we brought a clock, and we said, time's running out. Yeah. Do not let this legislative session end with this guy getting paid for his divorce and people really hurting because they don't have health insurance that they can count on.
Right, and that was, I'd have to say, an easy issue, relatively speaking, because the extremes were so obvious. You have, as you said, somebody personally enriching themselves with the blessings of their board, on the one hand, and others being asked to tighten their belts.
The other way to lobby, of course, is with food. Food is good. I'll tell one little war story. When we were trying to pass the initial legislation for Right Care, which is our Medicaid managed care program, we gave the legislators little apple pies, like the little Drake's Cakes apple pies, and we wrapped it in a piece of paper and a flyer that said, Right Care is as basic as motherhood and apple pie. Nice. And they ate up our apple pies, and then they passed our legislation.
That's great. Yeah, well, I'll have to just tell one quick story, too, because one of my favorites is that some years before this Blue Cross campaign, we were in a battle with Rhode Island Hospital, and a lot of it had to do with the staffing levels and the lack of resources that were being put to the bedside as compared with the extreme resources that were being put in the corporate office. The CEO at the time was making, well, this seemed like a lot of money at the time. It still does to me, but $620,000. And we made up a $620,000 bill. As a matter of fact, we made up about 75,000 of those $620,000 bills. And we engaged our members in distributing those everywhere. Every public event, big gatherings, McCoy Stadium or the Air Show, or our members were out everywhere handing those out, and people still, like you, talk about and remember that. It had quite an impact.
Yep. So we did get the clock moving with that action and everybody else's action. I mean, the other thing to be realistic about is that no one person ever is responsible for the passage of legislation. It is a coalitional experience. It's really rare that one person can say, I did this. So I'm always quick to say, we did this.
One person can be responsible for defeating legislation, however.
That is true. That is true. the people in the ability to say no, it can come to a choke point, and one person can defeat legislation. You're entirely correct.